Good day, everyone. Welcome to this session. We will continue our discussion on respiratory risk and breathlessness in telehealth care. By the end of this session, you will understand how to grade the severity of breathlessness using speech tolerance, activity tolerance, and visible work of breathing from a case description. Let's begin with why breathlessness is a high-risk symptom in telehealth care. Breathlessness is one of the most dangerous symptoms in telehealth because it may represent a wide range of conditions, from mild anxiety to severe respiratory failure, pulmonary embolism, heart failure, severe asthma, and pneumonia or sepsis. In telehealth, breathlessness carries extra risk because the clinician cannot fully examine the patient, listen to the chest, or directly measure the work of breathing in the same way as in person. This means the clinician must treat breathlessness as a risk signal, not just a symptom description. In simple terms, the key question is not only what is causing this breathlessness, but also how unsafe could this be if I am wrong? Next is, why is respiratory risk amplified in telehealth? Respiratory risk is amplified in telehealth because several safety protections are reduced or missing. These include 1. Reduced sensory input. The clinician cannot auscultate the chest, fully assess respiratory effort, or directly observe subtle perfusion changes. 2. Delayed rescue. If the patient worsens, time may be lost arranging transport, emergency response, or family support. 3. Patient self-management limitations. Some patients may not recognize deterioration, may not have home monitoring devices, or may not know when to seek help. And lastly is rapid deterioration potential. Respiratory illness can worsen quickly, sometimes before obvious distress is visible. Note: the same breathlessness becomes more dangerous when the clinician is remote and the patient is at home. Now we will look at how breathlessness severity can be estimated remotely. In telehealth, breathlessness severity must be estimated using information that can still be gathered safely and reliably from a distance. These clues help the clinician grade severity even when full vital signs are not available. Important remote severity clues include 1. Speech tolerance. Can the patient speak in full sentences, short phrases, or only single words? 2. Breathlessness at rest or on exertion. Are they short of breath only when walking or even while sitting still? 3. Activity tolerance. Can they walk a few steps, stand up, or perform basic tasks? 4. Visible work of breathing. Is there nasal flaring, use of accessory muscles, or obvious difficulty settling? 5. Mental status. Are they alert, confused, agitated, or drowsy? 6. Associated danger signs. Is there chest pain, fainting, blue lips, or inability to stay awake? And lastly is symptom trajectory. Are the symptoms stable, worsening, or rapidly worsening? In summary, we examine why breathlessness is high risk. We learned that breathlessness is dangerous because it may indicate serious conditions. In telehealth, it is harder to assess, so it must be treated as a risk signal, not just a symptom. Lastly, we also discussed why respiratory risk is amplified. We learned that risk is higher in telehealth due to 1. Limited assessment. 2. Delayed emergency response. 3. Patient limitations. 4. Rapid deterioration. And lastly is Estimating severity remotely. We have come to the end of this session. Thank you for watching. See you in the next session.